Welcome to Ask Dr. Mingle, the Q&A series from Mingle Health answering your questions about quality programs and the transition to value-based care. I'm Kyle Bruckle. I'm a digital marketing specialist here at Mingle Health, and I'll be hosting this episode along with Dr. Dan Mingle, founder and CEO of Mingle Health. Hi, Dr. Mingle.
Good morning, Kyle, and good day to all of you tuning in. It's great to see you again. I'm Dr. Dan Mingle, and I'm here to answer your questions to the best of my ability.
Well, we have 3 excellent questions for you today, so if you're ready, let's jump into them.
Bring them on, Kyle.
So our first question for you today, Dr. Mingle, is from Sean. And Sean asks, we are a single 10 MSSP ACO considering submitting Medicare CQM quality metric results. I'm unsure whether we are allowed to construct the JSON file ourselves that we'll submit on the QPP website. Obviously, we could use a registry to do this, but we already have all of our data at the ready, our list of ACO beneficiaries, and the ability to craft a simple JSON file. Is there any obstacle to me authoring the JSON file for my ACO quality submission myself?
Great question, Sean. Yes, you can submit it yourself, but there is a barrier you will have to overcome. Web interface reporting that just sunset was intended and designed to be self-serve. But to submit Medicare CQMs, you have to be a Medicare qualified registry. Your submission must include a valid registry identifier to be accepted. It's achievable. I built my first qualified registry when I was director of clinical informatics in the community health system in which I was a member of the family practice residency faculty. Since then, I've been involved in the creation of 8 additional registries, Mingle Health being my latest and greatest. The first step toward doing it yourself is to find and download Medicare's Qualified Registry Self-Nomination Toolkit. In searching for it to prepare this answer, it was a little difficult to find. I found it in the resource library on the qpp.cms.gov website. Download the 2025 MIPS guide to using a QCDR or qualified registry. In it, you'll find a link that will take you to the 2025 Self-Nomination Resources Toolkit. The toolkit is a zip file containing 4 PDFs that describe the requirements and the process for initial qualification and the requirements and process for annual maintenance of qualification. Initial qualification is mostly a set of attestations, assert that you have or attest that you have a certain set of skills, capabilities, and experience. Annual requalification involves demonstrating that you are reporting, that your reporting is accurate, and they'll get this just from the normal day-to-day actions of a registry, creating and following an annual audit plan, attending monthly mandatory meetings with CMS, and participating in random CMS audits as requested. You'll probably need at a minimum 3 FTEs buried in this process. 1, a subject matter expert, keeping eye on the rules and the proposed rules, the opportunities and threats, how they relate to you and your organization. 1 technical resource to manage the electronic processes that collect, analyze, format the submission, and submit the data, and an administrative asset to keep up with the Medicare requirements, connect to your practices to keep the accurate, usable data flowing. We have a massive group working on this, including about 7 people who read the rules every year to make sure we don't miss anything. I recognize that I'm more than a little self-serving when I say, leave it to the professionals. Don't try this at home, folks. I'm not sure I would still be a qualified registry if I were still working in a community health system and not fully dedicated to this work now. Now, no single requirement of the process is particularly difficult, but Medicare changes the rules frequently and sometimes with very little advance warning. There are a lot of details and obscure requirements, creating an environment in which small errors are easy to make. And some of those small errors can have big consequences. They can invalidate a submission, costing a healthcare system millions of dollars in uncollected shared savings or negative MIPS adjustments. Medicare publishes a list of qualified registries every year, and I'm seeing the number of registries diminish year over year. Attrition seems to be particularly large among the do-it-yourself organizations. Some of our happiest clients are those who have done it themselves in the past, now pleased to be free of the tedium. We're delighted to help you if you would be so kind as to engage us. It's what we live for. Great question, Sean. Thanks for that.
Absolutely. Thank you for the great question, Sean. And our next question for you today, Dr. Mingle, comes from James. And James asks, I just stumbled across a proposed bill to delay the requirement for ECQMs for ACOs submitting the APP Plus measure set. Is this proposal a good thing?
Great question, James. Bill you cite is the Healthcare Efficiency Through Flexibility Act that's been drafted and recommended by both the House Energy and Commerce Committee and the Ways and Means Committee. This short, direct, 794-word bill pertains to APP Plus reporting by MSSP, that's Medicare Shared Savings Program, ACOs. It proposes to direct CMS to postpone the sunset of MIPS CQMs and the requirement to use ECQMs until at least January 1st, 2030. It includes some language that CMS studies the process and protects organizations from financial loss if they aren't using ECQMs. The bill is endorsed by Vern Buchanan, a Republican congressman from Florida, Jimmy Panetta, Democratic congressman from California, Dan Crenshaw, a Republican congressman from Texas. It's also endorsed by several large healthcare organizations and the National Association of ACOs or NACOs. I think it's a great bill and I will be expressing my support and encouragement to the sponsors and to my own congressional delegation. If I could recommend any improvement on the bill, I'd suggest that Medicare never require ECQMs. Now, I believe that electronic reporting is good and desirable. Every organization should aspire to it, but it should never be required. To get to value-based care, there are two essential outcome measures of value-based care. That's quality of care and cost of care. Nothing is more important to value-based care than to measure, compare, and improve quality and cost of care across all healthcare organizations in the United States. Against those goals, everything else is of trivial importance, including whether reporting is done with fully electronically, fully manually, or a combination thereof. If electronic reporting is, in fact, effective and efficient and save costs for a healthcare system, it will be adopted by healthcare providers when and if those barriers have been addressed adequately. Anything faster than that, any pressure before it's actually efficient and effective, is going to waste money and make our healthcare system less value. Mandating the change earlier than the industry is ready can only hurt healthcare systems, providers, and ultimately patients. In fact, as much as I believe in electronic reporting, I think everyone should be doing it. I think all manual reporting is bad. It's unsustainable. It's unscalable. It's too much work. It's too expensive for the output. All electronic reporting is achievable and is sustainable and scalable into a complete system of monitoring and assuring healthcare quality, not just with a handful of measures for MIPS or ACO compliance, but for 70,000 potential evidence-based requirements of our 350 million United States residents. I believe in a robust, complete healthcare quality measurement system. But the most accurate reporting, the most efficient reporting will always be electronic with manual oversight and augmentation. Once it completes its circuit of the House and Senate, who knows how this bill will be amended or what unsavory other actions it might be bundled with. But for now, I support the bill as written and hope that you will as well.
Great question, James. Thank you for sending it in. Our final question for you today, Dr. Mingle, comes from Corinne. And Corinne says, I have a question from a small practice MIPS participant who is using eClinicalWorks. Would they need to hire a third-party vendor to validate their EMR for promoting interoperability? Or do you know if there is an exemption available for small practices for the PI category?
Great question, Corinne. There is a small practice exclusion from promoting interoperability. That is the MIPS performance category. Practices with 15 or fewer providers have an automatic exception. You can confirm that your small practice has that exception on the qpp.cms.gov website. Enter your National Provider Identifier, that is your NPI, into the Check Your Participation Status dialog box that's prominently displayed on the homepage, and it will tell you whether Medicare currently considers you a part of a small practice. Now, as to vendor validation, EHRs validate themselves. To call themselves certified, they must, through an examination by a certifying vendor, meet the relevant certification standards set by the Office of the National Coordinator, or the ONC. Now, certification is modular. An EHR might provide the whole certified product, or you might be using elements of multiple products that together make a fully functional, wholly certified system. If the product you are using is homegrown, or critical parts of it are, then you can seek your own certification. The system, as you're using it, has to meet the certification standards through examination by an independent certification vendor. But that is occasionally done. Most people are relying on the vendors themselves to do that certification. And you're probably not going to be approaching that if you are, in fact, at or close to being a small practice. Now, most of us use a product or a suite of products that are certified. If that is your case, you simply need to create and download a certification ID from the healthit.gov website. You can engage a third party to help you, but the process was designed by the ONC to be self-serve without too much time or hassle. Go online to the Certified Health IT product list. That's CHAPL, CHPL. Follow the instructions at how do I create a CMS EHR certification ID. You will search for your product and version number, and if certification is confirmed on the site, you'll push a button to add it to your certified products list to create your own unique certification ID. You'll enter that into your system along with the required reporting, which should come right out of your EHR, and you'll hopefully score well on your Promoting Interoperability performance category. Thanks for the great question, Corinne.
Yeah, thank you, Corinne, and thank you to Sean and James as well. And thank you, Dr. Mingle, for sharing your insight with us today.
Thank you, Kyle, and thanks to all of you for the great questions. I want to be helpful. I want us to be useful to you. Don't hesitate to correct or supplement my answers. Share your experience. Ask your questions. We can be smarter together.